Welcome, everyone. Thanks for joining us today. My name is Jonna, and I'm going to help Dr. Blanton be the moderator today. I wanted to just let you know about some features that are part of the GoToWebinar panel. Down on your right-hand side, there's a questions area. So throughout this webinar, if you do have questions, feel free to chat them to us, and I will read them to Dr. Blanton to address at the end. Without further ado, I'd like to introduce Dr. Christopher Blanton.
Thank you, Jonna. Welcome to the keratoconus treatment webinar. Today we're going to talk about the disease of keratoconus and what the current status of treatment and therapy is for this condition. So let's begin by defining keratoconus. So the cornea, which is where keratoconus takes its effect, is the clear dome-shaped part on the front of the eye. And the problem in keratoconus is there are at least one or two abnormal proteins that lead to a thinning of the corneal tissue, and in fact it gets so thin that it begins to bulge, and this bulge creates an abnormal shape on the front of the eye, and it leads to vision loss. We typically see this in young people, and it can progress, and that progression is part of the whole reason that we have now started to do different new therapies for the treatment of keratoconus, because our goal is to prevent the progression of the disease. So what kind of symptoms does keratoconus cause? Well, first and foremost, patients have blurry vision with this abnormal shaped cornea. And many of these patients are wearing contact lenses to correct their vision. And from that, they get light sensitivity and eye irritation as the contact lens rubs on the front of the cone. They can get glare, ghosting, or double vision. And eventually this can lead to permanent vision loss if it isn't properly identified and treated. So I'm going to kind of review what we did in the past and what we're doing today. So the initial treatment option for almost all keratoconic patients is prescription glasses. And for many people, this will provide satisfactory vision. But if the disease progresses, at some point, the glasses no longer work well, and the patient is losing vision even with their best prescription. And at that point, we typically go to a contact lens, and the contact lenses that work best are the hard or rigid contact lenses. As you can imagine, that hard shape allows us to change the shape of the cornea and to kind of fix the bulge, so to speak. So many people, though, even despite needing contact lenses, their disease progresses, and even at some point, the contact lenses may not work. Now, so we've gone through glasses, we've gone through contact lenses. And about 15 or 20 years ago, if that was the case, then the only option at that point was a corneal transplant. And a corneal transplant is an invasive procedure in which you receive a donor cornea from a deceased individual. And for the rest of your life, you have someone else's cornea. You have the risk of rejection, and you have the risk of susceptibility to trauma. So although a transplant did a nice job of correcting the vision, there were inherent risks and problems with that surgery. And so over the last several years, two new surgical therapies have emerged for the treatment of keratoconus. In 2005, the FDA approved the intact corneal implant. So it's been around for almost 17 years now as an option for treating keratoconus. But many surgeons are not aware of it or have not been trained in the placement of intacts. And so it kind of didn't go very far. And recently, corneal collagen crosslinking has been approved by the FDA only within the last year or so. And collagen crossing is a mechanism of stiffening or strengthening the cornea. And the implants, the intact implants, basically reshape the cornea through the use of an implant. And we'll talk a lot about that this afternoon. So I choose intacts, and I'm going to spend the next few minutes telling you why that I think that is the best procedure, the best surgical procedure for keratoconus patients. So just to give you a little history, intacts first came out as a treatment for nearsightedness because when you place them in the cornea, they flatten the cornea. But they never really caught on because LASIK was so popular, it worked so well, patients were so happy that intacts never really took hold. But there was an ophthalmologist in France, Dr. Joseph Collin, who thought, wow, since these devices flatten the cornea, who else needs to have their cornea flattened? Keratoconic patients, patients with a bulge in their cornea. If we can flatten their corneas, we can improve their vision. And so he took 10 keratoconic eyes in 10 different patients. He implanted the intact in their eye, and in those 10 eyes, he noticed a dramatic improvement, not only in their uncorrected vision, but in their best corrected vision, their vision when they were wearing glasses or contact lenses. He also noted that every patient had a decreased cone or improvement, a normalization of their cornea in all of these patients. This was published in August of 2001 in a very prominent journal known as Ophthalmology. So this has been known for over 20 years that these Intact devices improve keratoconic patients. Now, how do they work? They are very small, micro-thin implants that are inserted into your cornea. And the procedure is very quick. It only takes 5 minutes. So when these devices first came out, there was a special kind of device used to make the tunnels. And that worked okay. But what we discovered later on, and we've been doing this now for over a decade, is that there is a laser that makes a much better tunnel for these implants. And so now we use the laser to create the tunnel. And the laser treatment only takes about 6 seconds to create these tunnels in your eye. And then we just simply put the implants into the tunnel, and we put one stitch, one suture into the cornea. We bury it so that you don't feel it. And then after a couple months, we take that stitch out of the eye. It's very simple and easy to do. So the way these things work is that they reshape the curvature of your cornea by adding these segments, and basically it pulls the cornea flatter. It takes that bulge and straightens it out for you. And as mentioned, everybody gets better visual acuity. Their uncorrected acuity improves, their best corrected visual acuity improves. But just to be fair, just to be transparent, patients still need some form of correction usually, whether it's glasses or contact lenses, but they see so much better. And for many patients who could not wear a contact lens because their cornea was bulging too much, now they can wear a contact lens. And for many patients, the glasses prescription becomes less because their corneas are flatter. They don't need as much prescription to correct their vision. So basically, they get better in almost every way that we can measure. So the benefits are, not only does it fix the keratoconus or help flatten out the cornea, it corrects some of the nearsightedness that's caused by the bulging cornea. It's essentially invisible. The only people who can see it are eye surgeons who are looking through a microscope at your eye. They can see the Intacts, but if you're walking down the street, nobody can tell that you have these in your eye. They're deep in the cornea, so you don't feel them. They're very comfortable and they're maintenance-free. Once they're in, they're in. You don't have to worry about them. Your cornea now has a new shape, a better shape, a shape that allows you to see better. So about 2 years ago, we did a study. We were very interested in telling the world and other surgeons about how well these things worked. So we put together 130 cases. Now, not all the cases were for keratoconus, so we didn't include those in the study. And this has been going on we've been doing this since 2005, so some of the charts were unavailable because they simply weren't around anymore because they were older charts. So we had 113 charts to review for the study. And in those 113 charts, only 3 of the patients had to go on to corneal transplant. That's called a PKP, or penetrating keratoplasty. So only 2.6% needed a transplant, whereas, as I mentioned, 15 or 20 years ago, almost all of these patients would have needed a transplant because it's the only thing we had to fix their cone. So this has prevented a lot of transplants, which is a huge benefit to keratoconus patients. Now, we have 2 of these patients of the 113 who are saying, look, I like what the Intacts have done for me, but I want more. They're requesting the crosslinking. I'll talk about crosslinking, how that works, and how we utilize it in conjunction with putting the Intact implants in. So every surgical procedure has complications. Fortunately, with Intacts, they're very rare. So of the 113 cases we reviewed, we had 5 complications. One was we were unable to place the superior segment. In other words, there's 2 segments, an inferior and a superior segment. In one case, the tunnel that was created by the laser didn't allow for the placement of the superior segment, but that patient actually got better just by having 1 segment in the eye. Every now and then, the eye tries to extrude these implants. And so in 3 of the cases, we had to remove the implant, but the patient did not have any vision loss. We just had to take the implant out. And finally, 1 patient developed what we call hydrops. Hydrops is swelling or corneal edema. Now, hydrops can occur in keratoconus patients that don't have Intacts. So we're not sure whether this hydrops is going to happen anyway, but just to be transparent and completely honest, it happened after the Intact, so we're including that as one of the complications. But you can see out of 113, only 5 complications, so well over 95% success rate. And even in the complications, they weren't devastating. They didn't cause horrible visual loss or anything like that. So this is our graph of uncorrected visual acuity. And what we're talking about is when you test a patient's vision with no glasses or no contact lenses. On the left is the preoperative value. These patients, the best they could see on average was 2200 in their eye before they got the intact. And that 2200, by the way, is the level that we use to describe legal blindness. So their 2200 eye after the intacts went to 2060. So dramatic improvement. And just to explain what these numbers mean. When we say 2200, what we're saying is the letter that you see at 20 feet, the average person can see 200 feet away. So that's not very good vision, as you can imagine. As the lower number gets lower, that means the vision is improving. In other words, what you see at 20 feet, most people can see at 60 feet. So better than 200 feet away, right? So dramatic improvement in the uncorrected visual acuity of patients that had intact placement. And the 20/60 level is almost to the point of legal driving. And that is uncorrected vision. In other words, before they ever put their glasses or their contact lenses on. So how about best corrected? Best corrected is when we actually give them their best prescription. So before the surgery, the average best corrected vision in these eyes was 20/70. In other words, even with their best pair of glasses, their eye was not legal for driving. It was unacceptable to the DMV. After the surgery, 20/40, legal driving vision in these eyes. So on average, these patients developed 3 lines of visual acuity improvement, taking them from not being able to drive their car to being able to drive their car. Once again, a significant improvement once the intact lens was placed in their eye. So how does it work? It works by flattening the cornea. So on average, these corneas were flattened by what we call diopters, 2.4 diopters, 2.5 diopters of flattening, which means their prescription went from, let's say, a -6 to a -4, or a -4 to a -2. So in other words, they had dramatic improvement in their nearsightedness, in addition to having improvement in their uncorrected and best corrected visual acuity. And this is how Intacs works. It's also how collagen crosslinking is supposed to work, but collagen crosslinking doesn't give this level of flattening. In the best studies so far, crosslinking has flattened the cornea less than 2 diopters, so it does not match the Intacs, which is why I am in favor of Intacs as being the primary procedure for keratoconus patients, because it flattens their cornea more, gives them better uncorrected and better best corrected visual acuity. It's a very quick procedure as well, and we'll talk about the difference between now crosslinking and Intacs. So collagen crosslinking is a surgery where the skin of the cornea is removed, and then a vitamin B solution along with ultraviolet light are applied to the eye. The surgery takes an hour to do, whereas opposed to the Intacs, which takes about 5 minutes. The idea is that this combination of vitamin B and ultraviolet light increases strength of the cornea. As you can see by the little cartoon down below, there's a stronger bond between the layers of the cornea. Now, in order to do this procedure, you have to create a large defect on the surface of the eye, which is essentially like a sore. It makes the eye uncomfortable, and it causes the potential for scarring. Now, vision recovery is very fast with Intacs. Most people see better the next day. In crosslinking, the visual acuity recovery is delayed because the eye has to heal, and it takes weeks to months for the eye to heal. And in many of the studies, the visual acuity may be improved in some, not in all. And in fact, most surgeons doing crosslinking, the discussion with the patient was always, don't expect better visual acuity, just expect that we're going to halt the progression of your disease. So to me, Intacs offers so many advantages in terms of its ease of placement, rapid recovery of the vision, the comfort level of the patients, the dramatic improvement in the corneal flattening, and in the uncorrected and best corrected visual acuity. So Intacs, as I mentioned, there's minimal discomfort. You might feel the suture for the first day or two, but then since it's buried, you don't feel it anymore after that. With the crosslinking, because you have this large defect on the front of your eye and you've had ultraviolet light applied to your eye, there's significant discomfort, which requires oral medications, drops, a contact lens, many kind of mechanisms to try to decrease the discomfort on the front of the eye. Now, the insurance coverage is a critical element for many patients. Since the FDA approved this back in 2005, almost all insurance companies will cover the Intacs. I can't remember the last time that an insurance company denied coverage of these. So it's a very well accepted standard. and almost never do we have a problem. On the other hand, cross-linking has only been around for a year or two in terms of FDA approval. And so many of the insurance companies still consider it experimental, and many of them do not cover it. And we have had a great deal of difficulty getting insurance coverage for crossing, and we're not the only ones. Almost every practice is struggling with this. And so it's another kind of like, there's a problem with cross-linking that is difficult to overcome. So one of the benefits of crossing is, yes, it clearly halts disease progression. That has been demonstrated in numerous studies in Europe and Asia, and finally why they got FDA approval. But it's my assertion that I think Intex does the same thing. There are now a couple of studies out showing that these patients are stable after 5 years, and we think they're stable. We've been doing this for 15 years. So I believe that Intex also halts the progression of disease. In order to make that claim, it would be nice to see a scientific study demonstrating that. But I think we have enough evidence at this point, just anecdotally, to suggest that there's a very good chance that Intex does the same thing, that it halts the progression of the disease. And as you remember from the first slide that we showed you, one of the big problems with this condition is that it can progress. And when it progresses, it can progress to the point where there is actually permanent vision loss from scarring or from the need of a corneal transplant. So there is a new kind of mode of thinking, and that is when someone is diagnosed with keratoconus, it is now a kind of standard of care to intervene. We need to do something. We need to stop the progression of the disease. And so the two main therapies are, as we've mentioned, the Intex and the cross-linking. And for all the reasons that I've described, I'm favoring Intex right now as my procedure of choice. Do we do cross-linking? We'd be happy to do cross-linking on somebody as soon as we can get their insurance company to approve it. So we have a couple cases that we're waiting on right now to add to the Intex. In other words, you may get kind of a 1-2 punch if you do both the Intex and the cross-linking. So that's on our agenda, but I still feel like Intex is the best procedure for keratoconus patients. So as you can tell from my talk, that's my preferred method for the treatment of keratoconus. And I am happy to answer any questions that anybody in the audience has about all of this discussion. Please feel free.
Perfect. So far, no one had asked a question during the session, but I'll open it up here to let them chat now. So feel free to chat us your questions. Give it just a few more seconds here. It might be a quiet bunch today.
Mm-hmm.
This is not an audience question, but I know it's something that is new with the practice. And today we are presenting from our Pacific Eye Institute affiliation, but Dr. Blanton actually does the procedures out of the Inland Eye LASIK office. I don't know, Dr. Blanton, if you want to touch on that and why you do your procedures there, just so everybody knows.
Sure. So we're part of Pacific Eye, which is a large group. We have multiple sites all across Southern California, and we even have we're partners with some groups in Minnesota as well. But the way we do Intex is we use an interlaser laser. This is the laser that creates the tunnels. As I mentioned, it's a very quick 6-second procedure. And the interlaser laser is located at our Inland Eye LASIK office. It's the same laser that we use to make flaps on the front of the eye when we do the Intex, when we do the LASIK procedure. So that's the office that we do the Intex in, because when you make the tunnel with the laser, it works very, very well. So that's why we do all of our cases here. And that's in Rancho Cucamonga on Haven Avenue, just north of the 10.
Perfect. Someone asked, is it common for doctors to require progression before suggesting treatment?
That's a great question. So typically progression is, it's hard to define, but let me tell you how I feel about it. So first of all, many of the insurance companies will not approve the collagen crosslinking until you have demonstrated progression. And so that means they need at least 2 exams showing that the eye is getting worse. But my argument is that as soon as the patient comes in, they're coming in to tell you they're getting worse. So that, to me, in and of itself, demonstrates progression. So in other words, the minute you begin to lose vision, we shouldn't wait any longer, because that's telling us you are progressing. people don't start with poor vision, they develop it as the disease progresses. So to me, that is the hallmark of progression, is when they first come into my office and they can't see 20/20, all right, you have already shown us that you're progressing and we need to do something now. The insurance companies, especially with cross-linking, are going to require multiple visits to demonstrate progression, and they measure it in several different ways. Is the cornea continuing to bulge? And you can measure this with map-making devices. Is the vision deteriorating? Is the astigmatism advancing? Is the cornea becoming steeper? So all those things are ways of developing progression. So as you can imagine, you have to go through this process, which is kind of onerous. It takes time, takes visits, which is kind of why it's so hard to get this thing approved from the insurance companies. And what I'm talking about is cross-linking. Intacs, as I said, they don't require the progression. This thing has been approved since 2005. Almost all the insurance companies say, yep, go ahead. So that to me makes everything easier for everybody, including the patient in terms of convenience and scheduling and getting things done. And for the surgeon, not having to kind of demonstrate what is already obvious, that the patient is progressing. So I hope that answers the question for you.
Perfect. A couple more have come in. So
okay,
my
good.
son already has the hard rigid lenses after cross-linking procedure. Do you still recommend the Intacs procedure?
It could certainly help. In other words, if they've just had cross-linking and not Intacs, yes, that's still a 1-2 punch. You can actually get more benefit from the Intacs, and there are a number of studies out there in which they're combining the two, and it seems to be a reasonable thing to do. So certainly worth evaluating. So if that's the case, I would recommend coming in for a consult. We'll take a look at the eyes and we'll see if there isn't something that we can do. So that's certainly a reasonable thing to consider.
All right, this is kind of a two-part question. I had Intacs done many years ago, but only one in each eye because inserting the second set was proving difficult. Should I try again? And that same person also said, I don't remember if the incision was done with an instrument or a laser. Would that matter? Could that be why the insertion was difficult?
If you had it done a long time ago, it's almost for sure that it probably was not done with a laser. So yes, that could have been why it was difficult. Now with the tunnels, it's much easier. In order to suggest adding another segment to your eye, I would have to look at your eye and see where it's at and how it's placed and all that kind of stuff. But it's reasonable to think about putting a second one in, and whether or not you get a benefit, it's hard to say. There are some studies out there where people have shown that even with one Intact segment, you get some improvement. So would you get more with two? We don't have enough people out there like that to make a claim like that, but it's certainly a reasonable thing to suggest that that's a possible thing to do and you could have some improvement.
And then what is the recovery time, and do you have to wear those goggles after?
Okay, so the recovery time is fairly quick, and what I mean by that is because these Intacs are deep in the eye and most people feel pretty good the next day, they can do most activities. We don't want you to get hit in the eye, so we'd recommend, staying away from things like racquetball and karate and hockey and stuff like that for a few weeks. But most people can go right back to work, especially because we're doing their worst eye first. So their better eye is still capable of seeing, so they can drive their car and do all that kind of stuff. So recovery is very fast with Intacs. I'm sorry, what was the second part of the question?
And do you have to wear those goggles?
We have you wear a clear plastic shield. On the day of surgery, you wear it for about 18 hours. You wear it all day and all night, and you take it off the next morning. After that, after the first day, you just wear it at bedtime for 1 week. During the daytime, you don't need to wear anything other than whatever you normally wear, glasses or whatever.
So the person who asked about their son, my
Yes.
son already has the hard rigid lenses after cross-linking procedure. Do you still recommend the Intacs procedure? They followed up with, but would they still need to wear contacts?
It's possible. It's hard to say without evaluating them. They almost always will need some form of correction, but many times after the Intacs, we can take somebody who could only wear contacts and now they can get away with just wearing glasses. So it's possible that we could decrease the need to wear the contact lenses.
Perfect. Are there any other questions today? Oh, actually, there is one more. What is the age at which you're able to do the procedure? Starting age.
It really depends on the maturity of the patient. In other words, the crossing has been approved for age 14 and above. I think that's a reasonable number to start with the Intacs. So do you have a mature 14-year-old that can lay still for 5 minutes? I can do that patient. But if they're fidgety and nervous or immature or whatever, then they're not going to be a good candidate until they can lay still for 5 minutes. But 14 is where I would start.
Okay, perfect. And someone
And
just
this is
said
a young
thank you.
person's disease, so we see people like that all the time who in their teens are developing this problem.
And then someone just gave you a shout out. They said, okay, thank you. I did get improvement and feel very fortunate to have one set, but definitely would like to see better. You did my Antax and I would definitely recommend.
Great.
So someone also just chimed in, I was recommended corneal surgery due to severe progression. Would Intact still be an option?
Maybe. Depends on how bad the progression is. If you have dense scarring in the center of the cornea, then it's too late for Intacs. But we don't know that until we look at your eye under the microscope. So come in for a consult and we'll take a look and tell you.
Perfect. Is there any other questions today? Give you guys one more minute here and then we'll wrap up. And then Dr. Blanton, with the consult, what should they expect? Any meeting with you, etc.? Like kind of just run through what to expect at that consult.
Yeah, so basically when you come in, what we're going to do is we're going to measure your current glasses prescription. We're going to take maps of your eye. We're going to do our own refraction to see what it is that makes you see the best. And then using the maps of the cornea, we're going to assess whether or not you're a good candidate or not. And of course, we want to make sure that you actually have the disease. And by the way, most people who come in, we already consider them to have progressed. That's why they're there. They're seeking assistance because something's not correct with their vision. So once we've established that there's actual keratoconus there, then it's a matter of doing an eye exam and talking to their insurance company about authorization.
Perfect. Well, that looks like all the questions today. Thank you everyone for attending. This will be made available afterwards too via recording. So watch your inboxes for a copy. Again, thank you everyone for attending and we hope to see you at the practice soon to see Dr. Blanton. Thank you everyone.
Thanks, Jana.
Thanks. Bye.
Bye-bye. Bye-bye.